prostate cancer is rapidly rising in Asia. You can see that compared to the North American or even our neighbor Australia, New Zealand, actually the incidence of prostate cancer in Philippines, China, Singapore are all increasing rapidly. And this is probably partly related to the aging population and also the westernized health lifestyle and also the increasing awareness of disease. So, in fact, because of seeing this rapidly increasing incidence of prostate cancer in Asia, led by Dr. Akasa, a group of urologists from different parts of Asia have joined together to form a database to study about the prostate cancer situation in Asia. And this is the ACAP database. And from the ACAP database, the program started in 2016 and had more than few thousand patients have been recruited into the database. And these are some of the basic information we gather from the database. You can see that, in fact, even in Asia, we have a different healthcare system, but overall speaking, still quite a lot of our patients actually presented with quite late with PSA more than 15, around more than 20% of patients are having PSA more than 50, and also more than an average around more than 30% of patients having a high-grade cancer with presence score more than 7. And with an average, more than 20% of our patients are presented with a metastatic disease, and also primary ADT is still one of the most commonly used treatment in our Asian patients, with more than 20% of patients receiving this primary ADT for their first-line treatment. And therefore, you can see that despite the high increasing incidence of prostate cancer in Asia, actually still quite a lot of our patients are having high PSA, high grading, and also metastatic disease at their presentation. And primary ADT is something very commonly used in our patients. And therefore, in order to have a better understanding about ADT in our Asian patients, I have worked with a group of urologists from Asia to start a database called the REDTIS database. It's actually the real-life evaluation about the effect of ADT in prostate cancer patients. In this prospective multi-center observational study, we are recruiting patients at newly diagnosed prostate cancer, and then if they are planning to start on ADT, then we will recruit them in this study. Currently, there are 6 centers, including Hong Kong, China, Taiwan, and Malaysia, are joining in this study. And after informed consent, the baseline characteristics and blood tests will be done, and then all the patients will have regular monitoring about their blood parameter and clinical parameter every 6 months. And last year in the UAE meeting in Seoul, the virtual one, we have presented our data about the finding from this REDTIS database. And since the starting of our database in 2016 up to 2020, we have already 400 patients have been recruited in this study. And in this study, we have these patients have been for more than 18 months, 1.5 years, and we are trying to see the change in the metabolic situation and also the Framingham risk score in this patient. In this 400 patients, the average age was around 72, and around half of them are having metastatic disease. You can see that at the baseline information, more than half of the patients are already having hypertension, and around 1/4 of them having diabetes or dyslipidemia, and also 10% of them will having coronary heart disease. If you're also looking at the ACAP database, we can also see that around 20% of patients will already have diabetes at their presentation, and also around half of them will having hypertension. So it's quite comparable to the global situation in Asia. Therefore, in our patient in Asian or even in our prostate cancer patient, actually CV problem is not uncommon in our patient. And so from our REDTIS database, we can see that after 18 months of treatment, we can see that for this kind of this group patient, and actually there's a gradual increase in body weight in all the patients across the group, and also the lipid profile in the total cholesterol and also triglyceride also increased over the 18-month period. And besides the lipid, actually the sugar profile, the fasting sugar or the HbA1c is also worsening. Therefore, you can see that over the 1.5 years, actually many patients are getting more obese and also having more higher lipid level in the blood and also high sugar level in the blood. But besides that, actually, the hemoglobin level and also white cell level will be decreasing. Therefore, the marrow is also being affected during the treatment. And if we're looking at the fermentation risk score, you can see that from our patient, actually the risk score is gradually increasing over 1.5 years. Therefore, you can see that actually there's an increasing cardiac risk in this group patient after treatment on ADT. So therefore, serious risk can be increased after ADT treatment, and I think this is quite universally observed in patients receiving ADT therapy. So from this kind of build-like data from the ACAP and also from our database, we can see that actually the incidence of prostate cancer is gradually increasing in Asia, and unfortunately, many patients still presented with quite late disease with high PSA, high Gleason score, and so metastatic disease, and therefore primary ADT is still commonly used. And at baseline, already quite a lot of our patients are having a cardiovascular disease or metabolic disease, and death, and also this will be further increased or worsening during the ADT treatment. So these are some of the facts that we need to understand about our situation. So after knowing the fact, I have some thinking about how to try to improving the situation, how to manage our patient much better in order to minimizing the harm to the patient. And first, as we all know that the many patients are still presented quite late. Therefore, in a study from a small study from our center, found that actually patients present with body check and case finding, they have a much lower chance of having metastatic disease and also lower Gleason score. I think this is quite universally observed. And as a urologist, I think all of us should have this mission that we should encourage or promoting to the public that prostate cancer screening or early cancer detection should be something that we should consider, because it is the only way that can help to decreasing metastatic disease or improving the survival of our patient. How about the ADT? If our patients are really diagnosed at late and require the ADT treatment, are there any difference in the choice of ADT? And I think from previous talk from Dr. Rumura, and we have already get some idea. And this is the same paper that Dr. Rumura have been shared about the meta-analysis of some of the RCT performed on the use of GnRH agonist and also GnRH antagonist. And again, I just highlight some of the key points is that the antagonists have shown to have a better less musculoskeletal event and so better cardiovascular situation compared to the use of agonists. And actually, while the PSA progression was similar to the two groups, and for the overall mortality was less in the antagonist group. This may be due, the underlying cause may not be that clear, but it may be due to the decreasing of the cardiovascular event. It may be resulting in overall improvement in the survival of the patient. And besides this global data, actually in our Asian, we also have some local data from Asian group and from the Taiwan group. They have based on the public medication reference data, they have performed a study to look into the cardiovascular risk in those patients receiving GnRH agonists and also GnRH antagonists. And in our data, they have recruited more than 10,000 patients, and then among that, around 10,000 was on GnRH agonist, and around another 700 was antagonist. And then they tried to do a 1-to-2 propensity score matching, and then they found they have around 600 patients on antagonist and another 1,300 patients on agonist for the comparison. And you can see that in the baseline parameter, although the overall incidence was similar, but you can see there's a trend suggesting that those patients using antagonists has slightly higher CV risk, including more history of myocardial infarction, more stroke, and also higher coronary heart disease, and all high incidence of hypertension compared to the agonist. This probably reflecting that when physicians consider the use of antagonist, usually we will be using that on those patients with higher CV risk. However, when you look into the survival of this patient, and in particular the happen of any major adverse cardiovascular event or CV death, you can see that for those patients on agonists, they have overall increase in the incidence of MACE and major adverse cardiovascular event and also increased CV death, despite at the baseline that these agonist groups already had less CV disease compared to antagonist group. Therefore, you can see that the use of antagonists in a group with higher CV risk, they can still providing a protective effect on decreasing the long-term adverse event and also CV death in this patient. Therefore, and another thing that I want to bring out is also have been mentioned by Dr. Umura is that when we face a patient with metastatic disease, when we consider systemic therapy, actually, besides we can have to have a good choice on about the ADT, we should also try to consider adding more treatment to the patient, because I think even in the EAU guideline had already said that for patients with M1 disease, we need to consider the use of combination therapy if as much as possible. It can be either in a chemotherapy or with the new AR targeting agent, because I think this will be the new standard in managing our patients with advanced or metastatic disease. Therefore, just some of my own reflection or some of the thinking about the in facing about the current prostate cancer situation in Asia. And we all agree that the incidence of prostate cancer in Asia is getting increasing. Unfortunately, still many patients present with high PSA or high Gleason score and metastatic disease. Therefore, being a urologist, we should keep on our effort to promoting or encouraging people to have a more early cancer detection in order to avoiding this late presentation of the disease. And we have seen that CV risk and also metabolic disease are quite common in our patient group, and also this risk will be further worsened after the use of ADT. Therefore, we should consider the use of a better ADT treatment with less CV risk, and this will be very important, in particular in those patients with high baseline CV cardiovascular disease. And primary ADT is still a mainstream treatment of our patient. And besides choosing the right ADT for our patient, we should also consider the use of additional therapy, either chemo or other new AR targeted agent, in order to providing the best care to our patient. And this will end my presentation. And thank you very much for your attention. And so after having the discussion, having the discussion by Dr. Rumura, there are already some questions have been submitted to the Q&A section, and therefore, I will start to presenting them. But at the same time, if you have further questions, please also submit it through the Q&A section, and we can also discuss the question together. So, Dr. Rumura, there's one question about the use of LHR agonist and LHR antagonist. While clinically, when we're using the drug, we didn't see much difference in the effect. Can you share your experience about how any difference in really how in your experience how you observe the difference in the treatment effect by using the LHR agonist and also LHR antagonist? This one, the first question.
Yeah. Thank you very much for the questions. I prefer the GnRH antagonist for the patient with metastatic disease. For example, bone metastasis or B-cell metastasis at the diagnosis or initial diagnosis. So we use the LHRH antagonist rather than LHRH agonist, because we want to reduce the testosterone level promptly by start the hormone therapies.
Okay. So I also have one question. During your sharing, you mentioned that the use of antagonist, the degrader, will help to decrease the PSA further. And so, do you recommend that when we have a patient using agonist and with a PSA rising, despite the testosterone level is very reaching the castrated level, do you still recommend us to try to shift to antagonist to see whether there's any further improvement in the PSA control? I mean, do you only for those patients with PSA testosterone level not suppressing well to shift to antagonist, or you recommend even with a good suppression of testosterone, we can still try to shift to antagonist to see the effect?
Yeah. So as you know, GnRH antagonists reduce testosterone and dramatically, and after treatment of LHRH antagonist, for example, as his PSA was increasing, so we checked the PSA level and with testosterone levels. Yeah, I checked every time.
Yeah, but say if the testosterone level is already very well controlled at the castrated level, do you still consider shifting it to the antagonist to try to see whether it has effect on suppressing the PSA level again?
We usually change from GnRH agonist to antagonist, but vice versa is not so effective, I think. For example, from antagonist to agonist is I think not effect on the testosterone level and PSA change.
So there's another question that mentioned that one of the potential benefit for the is the suppression on the FSH level compared to the agonist. So, however, if for a patient, if the baseline FSH level is not that high, will you still consider the use of agonist or the use of antagonist?
We don't check the expression of FSH in the initial biopsy, but New England Journal report describes that FSH receptors exist in the prostate cancer tissue around the vascular cells, and I think when the prostate cancer occurs recurrence, so maybe lot of vascular tissue, vascular tissue, express the FSH receptors higher than previously. So we changing from antagonist to agonist to antagonist is effective to reduce the FSH level.
Okay, so that means we will because FSH is not commonly used in our special stain in our pathology, therefore probably it may not be helpful to help to guide the treatment, right? Yeah. So besides the use of antagonists in patients with with high cardiovascular risk, do you have any other advice to your patient in order to decreasing the CV event during the ADT treatment? So I know that the Japanese have a very healthy diet, but any other advice you will usually give to your patient if after they started on ADT?
Yeah, in some cases with urinary retention,